Good morning or good afternoon, depending what time zone you're in. Welcome to the Ovarian Cancer Research Alliance's annual conference in 2021. We're meeting again virtually, but we're so thrilled that you can join us. We're going to be having two Ask the Expert sessions, which are really some of the most enjoyable sessions, I think, for myself, my colleagues, and all of you. We're just sorry we can't all be there in person. I'm Beth Carlin. I'm a professor of obstetrics and gynecology at the David Geffen School of Medicine at UCLA, where I'm also vice chair of women's health research and the director of cancer population genetics at our Johnson Comprehensive Cancer Center. I'm joined today by my friends and esteemed colleagues, Dr. Ronnie Alvarez, who is the professor and chairman of obstetrics and gynecology at Vanderbilt University School of Medicine and the Burnett Endowed Chair, and my very good friend and esteemed colleague, Anil Sood, who's a professor and vice chair for translational research in the departments of gynecologic oncology and cancer biology at the MD Anderson Cancer Center in Houston. I think I can speak for all of us that we're thrilled to be here with you. And I want to applaud your community, the ovarian cancer survivor community, for your enthusiasm for this conference. We received over 100 questions, and we have two sessions. We're going to try to address as many of those questions as possible. In this first session, we thought we'd talk about treatments and new treatments for ovarian cancer, maintenance therapies, in both the upfront and in the recurrent setting. As you know from other sessions during the conference, PARP inhibitors have transformed our treatment paradigms for ovarian cancers. And many of the questions that came in focused on how we use PARP inhibitors. How do we use them? How do we choose them? And what is their impact on living with ovarian cancer? So I want to start out, and I think each of us can comment from our own clinical experience. Dr. Alvarez, I'll start with you, but how do you choose between a PARP inhibitor when you're treating patients, and how do you use them in your practice?
Well, I agree with you, Beth. PARP inhibitors have really been a paradigm-shifting new treatment for patients with ovarian cancer. And we have seen just a tremendous evolution in how we manage ovarian cancer patients over the past 2 or 3 decades that we have been practicing since we all finished our training many, many moons ago. But it's really exciting to see this new treatment that's been looked at initially, I think, in the recurrent setting for platinum-sensitive patients and platinum-resistant patients. But I think what's been most exciting is some of the new data that's come out about using PARP inhibitors in the upfront treatment of patients who are newly diagnosed with advanced stage ovarian cancer. And maybe my colleague Anil may want to elucidate on some of those new studies.
Thanks, Ronnie. Really great to be here with all of you. I really enjoy taking part in this kind of a conversation, and thank you for inviting me. I couldn't agree more. These drugs certainly have been a game changer. When we look across the different PARP inhibitors that are, there are 3 that are approved by the FDA already, and there may be 1 or 2 that additional ones that end up becoming approved. In our own group, in terms of in different settings, our group is kind of split in terms of which PARP inhibitor we use, and some of it really depends on the experience that individual practitioners end up having with the drug. Obviously, there are some differences in terms of their side effect profiles and which specific PARP inhibitor is approved for which specific indication and so on. But in terms of effectiveness, in general, they seem to be about the same. And as I was mentioning, there are some differences in terms of side effect profiles and so on. But these are certainly incredibly powerful drugs. there's still a lot of work ahead of us moving forward in terms of understanding what other drugs can be combined with PARP inhibitors to improve their effectiveness even more. And that's where a lot of the clinical trial development is certainly taking place at this point. And we can certainly go into that in more detail as well as we go through the session.
I think one of the things that you pointed out, Anil, which was really important, is that there seems to be pretty similar efficacy across these PARP inhibitors, particularly as they've been looked at in the platinum-sensitive recurrent group. And I think that in the upfront treatment of patients with newly diagnosed advanced ovarian cancer, we haven't had, the studies are a little bit different than what we saw in platinum-sensitive. But I think what was pretty consistent, either in the newly diagnosed sector or in the platinum-sensitive recurrent sector, is that the patients that benefit the most are those that have either a germline or somatic BRCA mutation. Then the group of patients that may have a homologous recombination defect, and those that have some benefit but limited benefit are those that are homologous recombination proficient. And that's been sort of a game changer, I think, in how many of us actually look in employing these types of PARP inhibitors. And some people are lumpers, and they will treat all patients with a PARP inhibitor in the maintenance strategy, or some will want to know what the BRCA status is and the HRD status is, so that we can be more precise about who we use PARP inhibitors in and manage the expectations about the potential benefits.
Yeah, Ronnie, and I couldn't agree with you more. I think you bring up a couple of really important points. One is to underline the fact that all women with ovarian cancer should have genetic testing and should have a panel test for not just the BRCA genes, but now we know that there's a whole family of genes that impact DNA repair mechanisms that can be inherited and place women at risk for ovarian cancer, but also set them up to be much more responsive to PARP inhibitors. So genes like RAD51C and D and BRIP1 and all are part of these panels. So I think it reminds us that all women, all survivors, if you've not been tested, really should get testing, not just in terms of your roles and targeted therapies, but also for your family members, to know whether or not they too could be at risk and can take preventative actions before they could get cancer. But also, you mentioned the somatic testing, that BRCA mutations can be inherited, but also the tumor cells themselves can acquire a BRCA mutation. That's tumor testing, which is different than the blood or the saliva testing that you do to see about germline inherited mutations. And those alterations in the tumor cells themselves also make them sensitive to PARP inhibitors. So as we allow women with ovarian cancer to live longer and longer, I do think that being in the era of personalized medicine, doing both genetic testing on the germline, genomic testing on the tumors themselves, will allow patients to avail themselves to clinical trials. The other thing that you made me think about is, just getting into the nitty-gritty, personalized medicine. We all look at, was a patient on her therapy? Did she have hypertension? And there are certain PARP inhibitors that have a higher risk of hypertension, like niraparib, and there's other PARP inhibitors that have a higher risk of difficulties with bone marrow suppression. And we look at some of those factors, at least I do, as I choose a PARP inhibitor. I think we all know all the PARP inhibitors do cause fatigue and nausea, and we do manage that. I know in my practice, patients, I sort of set them up for realistic expectations for those first few months on a PARP inhibitor. But after that, I've seen patients really be able to live very full lives. And I think that's what the clinical trials have seen about quality of life on PARP inhibitors. Has that been your experience as well?
For me, I think it's, again, I think it's been so paradigm shifting, particularly in the BRCA population. And it's probably a good time to mention, the latest data on SOLO-1, which was a trial that randomized patients who had advanced ovarian cancer and who had a BRCA mutation either germline or somatic, randomized them to get olaparib for 2 years versus a placebo. And when you look, we had some initial reporting about how well the patients who were getting olaparib were doing after a short-term 2 to 3 year follow-up. But then the most recent 5-year follow-up shows that almost half of those patients have been recurrence-free after getting 2 years of treatment with olaparib, which was reasonably, like you mentioned, Beth, reasonably well tolerated, and you could mitigate some of the side effects. But that's, to me, has been such a big game changer for people, for the 20% or 15 to 20% of people that have high-grade serous cancers and have a BRCA mutation.
Yeah, I can't underline that enough, Ron. I mean, to think we're actually possibly curing patients with stage 3 and 4 disease, and getting them to really have these longer survivals. It really, it's really changed the outlook. And I think what we want to do is, recapitulate that for the folks that don't have a BRCA mutation.
Absolutely.
And with regard to, I'm sorry, go ahead, Ryan.
Oh, go ahead, Anil.
I was just going to add that, as we get more experience with these drugs, we're also learning how to best give them and how to make dose adjustments and whether or not that has an impact, in terms of their effectiveness and so on as well. I'll just use niraparib as an example. There was a lot of concern about this particular PARP inhibitor affecting, for example, platelet counts or some of the blood counts and so on. But now, we're learning that if you, depending on what the platelet count is and what the weight of a given individual patient is, we can make adjustments even from the beginning. And even if there are toxicities for those patients that are on any of the PARP inhibitors, we've certainly learned a lot in terms of how to make adjustments so that they can continue to receive benefit from these effective drugs.
Again, as we've said, personalized medicine really is here, and it's being driven by our genetics and genomics. Both the individual woman's characteristics, but also that of her tumor will really help us choose the best and most effective treatment. Ronnie, you mentioned 2 years, and I think there were some questions about from the audience about how long one should stay on a PARP inhibitor and why. Do you want to address that as well?
It's so most of it is evidence-based to a large degree, and I think that the SOLO-1 trial was designed where the participants who were randomized to that arm were placed on olaparib for 2 years, unless they had some evidence of some measurable disease, and in which case they could extend the treatment. And as I recall, it was just a small fraction of people, less than I think 20% of people that stayed on olaparib for a longer period of time. So it's really makes the study even more impressive that once you stop therapy, you still sort of demonstrated a continued benefit for many patients that were on olaparib. And we have to take into consideration, again, the side effect profile of these drugs, the risk for long-term complications like MDS, the financial toxicity associated with that many patients experience in terms of having to bear the cost of these drugs too. So that all has to be taken in consideration.
Yeah, again, as we've seen in other trials this year, more is not necessarily better. That the trials have really seen that perhaps after 2 years, any residual cells really are being killed by the PARP inhibitors, which we know can also be therapies and not just used as maintenance. And that 2 years appears to be, at this point, based on the data, the optimal amount of time, considering, as you said, all the other things, quality of life, the fatigue, the risk of myelodysplastic syndrome and potentially leukemias, which, again, are at risk, especially in the recurrent setting as people have had more and more treatments, and the financial toxicity. So really, I think there is consensus that in general, patients should stay on a PARP inhibitor for 2 years. Anil, is that what you're doing as well?
Oh, absolutely. The only difference is that with niraparib, the duration, in the maintenance upfront setting in the clinical trial was for a bit of a longer period. It was for 3 years. But I totally agree with you that certainly that kind of a time frame certainly makes sense.
There were questions about PARP inhibitors combined with Avastin, recognizing that many patients are receiving bevacizumab with their chemotherapy in the upfront setting. When do you choose to continue or to add Avastin in the maintenance setting? Anil, how are you doing it?
We've discussed this a lot, and it's an important question because it does combine, two drugs that are expensive, and the history behind this whole combination, as both of you know, goes back to where the thinking was that those perhaps patients who had tumors that were not BRCA deficient, that there may be benefit, in combining these drugs. And the initial clinical trial looked quite interesting. But it turns out that in other clinical trials that were done a bit later, that particular group perhaps didn't really benefit as much. It was still the patients who had BRCA deficiency who really tended to benefit more. And then the question came up, well, would you have seen the same benefit just from the PARP inhibitor alone? So when we've gone through a lot of this discussion, at this point, we don't routinely use this combination, in our patients for a maintenance setting. Now, there are always exceptions. Say if somebody had, high risk setting, meaning that they had a cancer left after the surgery where there was quite a bit of cancer, or they had a lot of ascites or pleural effusion where you wanted to use perhaps a drug that helps to dry up that kind of fluid in addition to the PARP inhibitor. But I would say those are uncommon settings where we tend to combine it. For the most part, we tend not to combine these two drugs together.
That's been my approach as well, Anil.
Yeah, I think what's really interesting to me, and I'm sure to both of you, is that when we all trained and were early in our careers, we sort of had a one-size-fits-all approach to advanced ovarian cancer. We would do some sort of debulking procedure almost 95% of the time. We were happy when we got to less than 2 centimeters, and we thought that was optimally debulked. And then we'd use Taxol and carboplatin, or we used IP chemotherapy. And so now I think the decision-making process is much more complex and sometimes overwhelming for patients, because we're trying to think through, do I need to do primary debulking versus neoadjuvant chemotherapy with an interval debulking? And then my second decision is often, as you alluded to, Anil, is this a patient who's got really a big tumor burden, a big amount of ascites or pleural effusions? Am I going to use an anti-angiogenic? And then I start, thinking about the BRCA status and HRD status, and trying to figure out if I've decided to use Avastin, which I don't use a lot of, but across the country, many people do use it in combination with chemotherapy. And so then that sends you down a path of, and if I'm going to use an anti-angiogenic, do I continue that post-op, in the maintenance phase? And do I use also a PARP inhibitor? And again, does the BRCA and HRD status change how I may alter that maintenance therapy component? Where if she's just a BRCA mutation carrier, would I just go to a PARP inhibitor alone, even though I may have used Avastin or bevacizumab up front? Or will I just use bevacizumab if she's in homologous recombination proficient patient? So it's gotten to be very complex, and it's hard to sometimes to talk about all these different sort of steps for patients or pathways for patients than it was 20 years ago, when we had sort of, we're going to operate on you and we're going to give you chemotherapy. The end of story.
I think you used the term earlier, and I actually see your decision tree analysis and the various branches, we used to have one size fits all. And now we really do try to have personalized, individualized treatments for each woman for her tumor and take into account the other factors that are important to her and other medical factors in terms of when we use neoadjuvant chemotherapy versus primary surgery, when we add in bevacizumab or not, and all these other factors that you went through the decision tree. So it's really important for women with ovarian cancer to have a good relationship with their physician, to ask questions and to hopefully have trust in those decisions. If there's a question, second opinions sometimes help to help reassure you that indeed, you're on the right course. So it is much more complex, but in some ways it's really rewarding. It's really exciting to be in this era, thinking about how far we've come over these last decades and allowing women to live so much longer and live better despite having ovarian cancer. Just before we move on, just PARP retreatment. So let's say we have one of these women who got her 2 years of PARP and has done well, but 5 years later, 3 years later recurs, is platinum sensitive because she had this long platinum-free interval. What are the data on reusing a PARP inhibitor again? And Neil, do you want to touch bases on that?
Sure. No, I can certainly start. There's limited data so far, but there was some recent data that was presented that if the time interval has been substantial, then perhaps it may make sense. But outside of that, I think there are concerns, though, and some of those we discussed earlier, that with the longer duration and with repetitive use, number one, is there going to be benefit? And number two, is the risk for some of the other outcomes such as myelodysplastic syndrome or the leukemias and so on, will that rise? So I think it's still a bit early to know, about reuse of PARP inhibitors. And I think we're going to continue to learn about this question in more detail. But at least at this point, there is some data that perhaps with a longer interval, it may be okay to use these.
And there are ongoing trials of looking at PARP after PARP. So I think that, again, enrolling in clinical trials, availing yourselves of clinical trials as appropriate for you, but something else to think about. Ronnie, as you know, there were recent data about using PARP as a treatment for recurrent platinum-sensitive disease. Do you want to?
So I think we're going to be in a whole new era where we have defined most of the treatment paradigms for recurrent disease on the basis of whether we call somebody platinum-sensitive or platinum-resistant, and that's been largely defined as a time period, although we all know that that is not, that was on the basis of studies in the 80s and 90s when that's all we had was platinum. And I think just like we saw with chemotherapy, the longer time interval you had from your frontline treatment to the second line treatment, the more likely you were going to respond to retreatment. And that's probably applies also to PARP inhibitors, bevacizumab, and we've had studies coming out that show the efficacy of bevacizumab after prior bevacizumab. And just actually hot off the press today from ESMO, the Oreo study that suggested some benefit for retreatment with PARP inhibitor. But it's a whole new area because as we extend out the treatment-free interval from the completion of the first therapy, doesn't really mean that everybody's going to be responsive again. Or do we have to look at these categories like if somebody's a BRCA mutation carrier, you would expect somebody like that to be very sensitive again to further treatment, whether it be chemotherapy or PARP inhibitor. But then other patients who may have had some benefit from a PARP inhibitor may not get as big a benefit with the additional, second line PARP inhibitor. So there's much work to be done, I think, in a post-PARP primary care world that we now live in. And so I'm excited to see the studies that are be moving forward, looking at recurrence after PARP inhibitor.
Yeah. I was actually also excited to see data looking at PARP as a therapy that looked as good as chemotherapy for patients who had recurrent platinum-sensitive disease and had not received a PARP in the past. So when you have recurrent disease, indeed, a PARP inhibitor may be good to treat your tumor and not just to keep it from, in the maintenance setting, keep it from coming back. So I think that this new class of drugs and the way that they impact cells that are ovarian cancer cells, especially high-grade serous tumors, is very unique. And as we've been saying, those that have these genetic alterations that make them what we call homologous recombination deficient, or HRD, those are the ones that are really, really most sensitive.
Dr. Felix Rutledge wrote a paper back in the 60s about whether or not chemotherapy would replace radiation therapy in ovarian cancer. And wouldn't it be nice to see like Anil or you write a paper, will these new targeted therapies replace chemotherapy in ovarian cancer? So
I think that's the dream of all of us. It will truly have personalized, individualized treatments that are driven by those driver mutations, those genes that are making the cancer cell a cancer cell, and not just a general poison. So it's nice to see ovarian cancer on the way. Anil?
There is to both of your points, Dr. Weston here is actually leading a clinical trial where we're using a PARP inhibitor, for a short period of time in an upfront setting without chemotherapy. And, we'll have some data soon on this, but I think it certainly begs the question that, do some of these drugs really, should they be used earlier on? And again, it's a matter of time, I think, when we get answers to these kind of questions, again, in select patient populations, not in everyone.
So I thank you guys. I mean, I think this has been a robust conversation about one of the most transformative positive changes we've seen for women with ovarian cancer. A whole nother group of questions focused on immunotherapy. An exciting treatment paradigm for many cancers, lung cancer, melanomas, but we've not been able to realize that same benefit yet for ovarian cancer. Anil, can I ask you to maybe start on sort of where we've been with immunotherapies? And you don't have to go through every one of the trials, but I think really looking forward, how can we capitalize on this important biologic mechanism to improve tumor outcome, patient outcome?
Sure. So, similar to PARP inhibitors for women with ovarian cancer, immunotherapy has certainly been a game changer for many cancer patients, especially those with melanoma, and as you mentioned, for lung cancer and for certain other cancer types as well. For many types of ovarian cancer, immunotherapy so far hasn't perhaps worked as well. That doesn't mean that it won't. We just need to understand the biology in a lot deeper way. So, I thought I mentioned 3 points around this. One is that there are specific subtypes of ovarian cancer, such as patients with clear cell. And even within that, there are specific molecular abnormalities where patients who are treated with immunotherapy tend to respond a whole lot better. And there's another subtype as well, endometrioid subtype of ovarian cancer. So again, there are specific molecular changes that exist within these tumors that perhaps allow the immunotherapy to work better. So that's one. Now, moving forward to your point, as we understand what is so different about the ovarian cancer environment, meaning that within the tumor itself, that keeps the immunotherapy from working, and how can we improve that? And that's where I think some of the new combinations they need to be tested more. Already there have been clinical trials, for example, that have combined immunotherapy with bevacizumab. discussed. There are combinations that are being tested with even PARP inhibitors, and there are other new combinations that are being tested. So there are many forms of immunotherapy that are being developed. So that's another point I think that just deserves mention, is that moving forward, I'm certainly excited about the potential of immunotherapy, especially in these kind of new combinations. And then the third aspect is that, as we move forward, then we have to also try to understand what's so unique about specific cancer cells and cancer types, and can we exploit that environment, be it with vaccines, be it by engineering the immune cells outside of the body and then putting them back in and combining them with drugs that would allow these immune cells to do well, meaning in terms of attacking cancer cells. So those are 3 points that I thought I'd mention, but I'm certainly excited about the potential of immunotherapy.
Ronnie, you want to add anything?
Yeah, I think an important point to make is that maybe proving the potential of immuno-oncology in ovarian cancer is that we know ovarian cancers are immunogenic, right? They have antigens and express a lot of different antigens. We also know that when ovarian cancers are infiltrated by tumor infiltrating lymphocytes, some of the most sentinel studies that have been done in ovarian cancer that really set the basis for many other solid tumors was that when we see those tumor infiltrating lymphocytes in the histopathology slides, that we know that group of patients is likely to do better than those that don't have those tumor infiltrating lymphocytes. And so it's just proof of principle that there is an already endogenous process by which ovarian cancer cells can elicit a tumor response, and that can be translated into improved outcomes. And now, most of the newer studies have focused on checkpoint inhibitors, but I think Anil makes a good point that it's a combination of this paradigm shifting effort in checkpoint inhibitors together with other immuno-oncology strategies that may transform a tumor from maybe a cold tumor that doesn't have a lot of antigens and doesn't elicit an immune response to maybe more of a hot tumor that actually does express a lot of antigens, does initiate a inflammatory or an immune response to that tumor. And we use a number of different approaches to kind of affect a better anti-tumor response. We just haven't gotten there yet with just a checkpoint only inhibitor strategy.
Yeah, and I'll just jump in, to add that I think immunotherapy is going to be the next horizon for ovarian cancer. I think we're looking at combinations of not just one checkpoint inhibitor, but looking, again, the immune system is so complex.
Right.
There's hot and cold tumors in terms of the cancer cell itself and which antigens are on the surface, where we combine immunotherapies with things like PARP inhibitors or bevacizumab or chemotherapy even. But then there's also all the other types. We know from many tumors, even melanoma, you need to combine different targets, whether it's there's one PD-L1, there's CTLA4, but then there's TIGIT, there's LAG, there's all these other immunotherapy targets that can also now be combined. And Anil already spoke about vaccine therapies. There have been some positive trials on that. There's more and more coming. So while the current trials that have been completed to date have not brought immunotherapies into a standard of care realm, they haven't shown that type of benefit yet, I think that the ongoing trials, and just like with PARP inhibitors, those tumors that have homologous recombination deficiency are most sensitive. We know that there are subtypes of ovarian cancer. Some can be microsatellite insufficiency high, instability high, and that are really going to have great benefit from immunotherapy. So I'm still excited that there's great promise to not have a one size fits all, and to have really better outcomes for the patients with ovarian cancer.
I think what makes it a little bit more complex, and nobody studied this more than Anil has, is the tumor microenvironment. So the tumor cells don't live in a vacuum. They're surrounded by a very complex environment that includes immune cells and fibroblasts and vasculature, et cetera, and all of which contribute probably to a large degree in how that immune response is actually manifested.
Yeah, one of the questions that came in was, why do some patients respond to treatment and others don't? You know, it's almost a teleological question to be asking. And I think we talked about some of the tumor genomics, the microenvironment. Anil, perhaps you'd comment on that as well?
Sure, absolutely. And, to both of your points, again, there are certainly even immune cells that are obviously beneficial, but there are also those that can be harmful, or that can actually hurt the good immune responses. So there's a cell type called macrophages. Technically, that's also part of the immune system, but there are types of macrophages that the tumor can actually hijack and actually use that to promote tumor growth and the blood supply to cancers and so on. So there are a lot of variables, why certain patients will have a good response to immunotherapy. Some of them you've already mentioned in terms of the microsatellite instability or other molecular aberrations. But then there are other factors that, like Ronnie mentioned, that there are cancers that have high levels of hypoxia or low amounts of oxygen, that have other components to them that can actually keep the good immune system from entering the tumor and from attacking the cancer cells. But again, the deeper knowledge we get around these of these kinds of factors in the tumor, I think the more we'll be able to leverage or target these to help improve the effectiveness of immune therapy. And that's where I really do believe that science will drive the next generation of clinical trials that will be more and more effective.
So that's a good segue. I think we have a few more minutes in this session to really talk about some clinical trials where we're really basing things on tumor biopsies and looking at patients who have the highest likelihood of responding. I'm sure we all have many trials at our own institutions, but I do want to give a shout out that, those of you out there should discuss clinical trials with your physicians. They're not just when everything else has failed. Clinical trials really help us define the standard of care. And there are clinical trials really throughout your course of treatment that can basically be informing the next generation. As Dr. Sood, as Anil mentioned earlier, use PARP inhibitors instead of chemotherapy. I mean, there are many trials moving forward. Do you guys each want to choose a trial, mention something that, I can start, you guys can start?
Sure.
Go ahead. Oh, I mean, there are trials that are, the folate receptor alpha receptor on the cell surface has been really well targeted, and there's a number of trials ongoing, mostly now in the platinum resistant setting, but coming also in the platinum sensitive setting, using a antibody drug conjugate where the folate receptor is targeted with the antibody and a cytotoxic drug is then inserted into the cell. And we've seen many good responses with that drug called mirvetuximab that is also being used, as I say, in many settings, but that's a phase 3 trial that really has a good safety profile and has been very encouraging. Dr. Alvarez, you want to, I mean, we can all go on and on and on different agents.
Well, I think that, like you said, the most important thing is to inquire about clinical trials, particularly phase 3 trials that are looking at, a new therapy compared to the standard of care therapy, and to see whether or not we can make improvement upon what the standard of care can do. And so there are also earlier phase trials that are exploring either new first in human use of drugs or looking for efficacy. But so all of those are important, but the phase 3 trials are probably the ones that are most, cutting edge and paradigm shifting for us. And it's got us to where we've gotten today with the use of, Taxol and carboplatin and the use of PARP inhibitors and bevacizumab as maintenance strategies. So, and there's a whole number of studies that are being done with all sorts of new types of treatments, the majority of which, I just looked this up actually, and it was being done by our cooperative groups, and the majority of them fall into either immuno-oncology combination strategies or a lot of antibody drug conjugates, or new, what I would say, targeted therapies, drugs that are targeting specific molecular pathways in tumors. And so, when we were training or in early parts of our career, we were just merely looking at new cytotoxic drugs, and there are very few, if any, of those kind of trials that are out there now, because they're all focused on the different new classifications of drugs that I just mentioned.
Absolutely. And there were questions about those tumors that are homologous recombination proficient, but perhaps not as sensitive to PARP inhibitors. And I really, these types of trials really are going to lead to, I think, a new standard of care that will allow us to make that algorithm you were discussing earlier, perhaps a little more complicated, but benefit patients much, much more.
Exactly.
Dr. Sood, I know you have a whole long list of trials where you are.
Oh, thanks, Beth. And again, I couldn't agree more that, this is how we make progress in terms of doing the clinical trials. And they really cut across the entire spectrum, from early stage trials to more advanced trials and so on. But one of the perhaps important points that I'll just emphasize, that I know both of you also have done quite a lot of, is that we want to learn from every patient. So we try to focus on trials where we can have tumor biopsies before and after treatment, and also looking at blood samples and so on as well. And I think for this audience, I just want to emphasize that this is just so important, where we can learn why drugs work, but very importantly, why don't they work in certain patients? And then that way we can be smarter about designing the next generation of trials and so on. With immunotherapy in itself, I'm really excited about some of the combinations that are being tested now. Some of these combine immune therapies with vaccines. Some of these combine immunotherapies with other drugs that are designed to help improve the tumor environment, to help the immune cells penetrate. There are also clinical trials that look really exciting, where we're trying to the point that you brought up about patients who don't have homologous recombination defects. So one of the questions is, well, are there drugs that may combine well with PARP inhibitors, where you can extend the benefit from PARP inhibitors to a broader population? So we have some clinical trials now that are ongoing in that setting as well. So really look forward to these kinds of trials and data maturing.
Yeah, I agree. And I think the list of trials is so long right now. I had just mentioned one to give some specificity to it, but there are so many trials for you to discuss with your doctor, see what's available to you where you live. And I think it's, for me, been the most exciting time to be a GYN oncologist, because the science is so robust currently, and we're able to see women live longer and live better. And please keep coming back to conversations like this. Send us in your questions, and we will remain committed to finding better treatments to allow you to live better lives. Thank you. You can join us again at the next session, Ask the Experts 2. You'll see the same panel again. But I also want to call out to you that there are other sessions during this year's annual conference you may want to check out. Dr. Katie Moore from University of Oklahoma will have a whole lecture on precision medicine for ovarian cancer. And Dr. Stephanie Wethington from Johns Hopkins University will talk about managing recurrent ovarian cancer. So those are two sessions that could be, parallel with ours that you may want to check out as well. Thank you, and we'll see you in a few minutes.